everyone. My name is Greg Essenmacher, and I'm the Senior Business Development Director here at 3D Diagnostics. I'd like to welcome you tonight to our presentation, Advanced CAD Technology and Full Mouth Rehabilitation with Dr. Todd Engel, where he'll be covering such topics as appropriate patient selection, collecting accurate data, CAD design protocols, interim surgical objectives, and surgical process, including transitional phase. 3D Diagnostics is a world leader in computer-guided surgery, started with digital dental services in 2005, supporting the CT imaging department for a leading dental school out of Boston, Massachusetts. Offering a complete range of guided surgery services for our vast, predominantly North American customer base, from CT scans all the way to restorations. Our presenter tonight, Dr. Todd Engel, is originally from Southern California and currently resides in North Carolina. He's a graduate of the University of Pacific School of Dentistry, where he also received his doctorate of dental surgery. Dr. Engel is a diplomat of the International Congress of Oral Implantologists and maintains an active membership status with the following associations: Academy of Osseointegration, American Academy of Implant Dentistry, Academy of General Dentistry, American Dental Association, North Carolina Dental Society, California Dental Association, and Orange County Dental Society. Dr. Engel has extensive experience in dental implant rehabilitation, CT-guided surgical design, and complex treatment planning, as well as full mouth rehabilitation. Dr. Engel has hosted live radio, authored several articles, and has been featured keynote speaker both nationally and internationally on topics related to the field of implant dentistry. In 2005, Dr. Engel's lifelong dream of creating a learning institute where he could share, teach, and motivate other dental professionals was realized by the inception of the Engel Institute, located in Charlotte, North Carolina. The Institute focuses on live patient education with topics ranging from implant placement, grafting, and full arch conversion surgery. The Institute's implant courses have been taught across the US, and its alumni consists of well over 12,000 dental professionals. Please help me welcome my friend and colleague, Dr. Todd Engel.
Well, thank you so much, Greg. That's very kind of you. And thank everybody at 3DDX as well. Thank all of you for joining us this evening. If you've ever seen me speak before, you know that guided surgery is definitely a passion of mine. Before we get started, a couple disclaimers. I am not paid or endorsed by 3D Diagnostics or vested in the company. I'm a paid key opinion leader, but I do not vest in any sales, or I have no affiliation to the finances of the company. So that being said, I am fresh off a surgery that ended 1 hour ago, and at a mysterious place that I'll share with you in just a little bit to provide just what I think is just going to be an incredible evening of guided surgery, patient communication, and changing lives. So first, again, let me start by thanking Khalid El Sayed and all of the 3D Diagnostics folks for everything that they do, not only for all of you out there as with respect to education, but the fantastic work that they do. And Greg, thank you. That introduction was very, very kind. That being said, let's go ahead and start. As Greg mentioned, I am in private practice in Charlotte, North Carolina. This is my practice right here. It is a very unique hybrid type of a setup where we have a clinic and office with 7 operatories, as well as the teaching center, and they coerce in the center, as you can see right there, meeting in the middle of everything. And it's quite an interesting operation, and it's going to be something that I'm extremely proud of. If you've ever been there, then you know, and if you're on your way there, well, we're looking forward to seeing you. My practice is limited to surgery and the restorations of my own surgery. I have some really fun, interesting, new stuff to share with you. But yes, I am a GP. I placed my first implant 19 years ago. And ever since that first implant in the number 5 position, or for you all in Europe, it would have been the number 1-4 position. I've never turned back, and every day has been an incredible learning experience for me as a GP, learning this road and navigation of the surgical arena. It's been quite fun. I am a diplomat of the ICOI, and I'm very proud of that. And I, as Greg mentioned, have status in several other organizations. So let's move on. The mysterious place I told you about, I do live about 15 minutes from the office. On the left, you see the water. I spend a lot of my time at my house on the water, and on the weekends, and actually right now, I'm in, where the image is on the right, I have a farm. And that's my tranquility. People that meet me all over the world ask me, so what do you do for fun? What do you do to get away from all that you do professionally? And I will tell you, you're looking at it right there. I have a farm. We have pigs and chickens and goats, and we've got some llama on the way. And they're just wonderful. And it's really, really just an awesome weekend for me. And I'm here right now. It offers me some tranquility, and I'm going to pass that right over to you. So that being said, let's get right into it. You know, when I teach, whether it's beginning implantology all the way up to what we're going to talk about today, guided full mouth surgery, you know, one thing that I can't put into words enough as these doctors begin to learn this road course of big surgery. I think for me, after doing probably about 2,000 arches to date, I think for me, the biggest impact that I've seen is how I change people's lives. And we're going to talk about that throughout this session. I'm probably going to spend the next 90 to 100 minutes with you, and then I'll stick around for Q&A. But this is just going to be a real deal, me to you kind of share. This hasn't been rehearsed over and over again. It's just me, just coming at you. And if I could offer you anything at the beginning of this session, it would be this: always want to achieve greatness, but never feel that you've been there. And this will inspire you, if you love what you do, to be better. And every single day that I'm in my practice and helping people like you see here in front of you, Manelli, I try to improve. And there are still many, many ways I can improve, and I'm sure there's ways that you can improve. But as opposed to just looking at this as putting a couple guides on, dropping a few implants in, and screwing in some teeth and hoping that everything looks good and functions well, there's a person attached to that. And this person came into me, and as you could see, she's a class 3 bite, and she never thought that anyone would help her. She had, I believe, 5 natural teeth on the top. Her husband didn't even know she wore partial denture. And she was just really ashamed of herself. And as you could see, she's quite a pretty lady. Well, here was Manelli at about 4.5 months later, and she has a brand new lease on life. So when I look at this, the teeth are white, the teeth are square, they're exactly how she wanted them with all of our try-ins, and she looks wonderful. But this is something, when I look at the lady on the left who came into me, of course, she didn't have the teeth and the implants that she wanted. But when you look at her demeanor or her smile, as I asked her to smile, to look at a lot of things in her facial features, she gave me a defeated smile. And when you look at the new Manelli on the right, you see someone that is happy to be part of society, that feels that she has something to give, but really feels wonderful about herself each day when she brushes her teeth in the mirror. And to me, this is the gasoline, this is the petroleum for me and my engine and what I do. So let's talk a little bit more about this. Let's start with a workflow, the sequence of how I do things in the workflow. Now, you know, throughout this period that I was recreating some information and content for you, because I like to always be new and fresh, I was thinking a full arch guided surgery kind of module or idea in an hour or an hour and 15 minutes. Impossible. I've been doing it for 18 years, and I still could not tell you in 18 years what there is to know. So what I'm going to do reluctantly is I'm going to put this into chapters, and I say reluctantly because while it looks easy, or I might show you slides that look like they flow really well, I want you to always understand that there's a lot more to this than the hour and 15 minutes that I'm going to give you. And I'm going to keep saying that because this is a very complex, very surgically demanding, very just it's a craft of our platform, of our industry, that requires a very sharp and precise surgical acumen. And I'm going to pause on that because this is something that I've worked on for years, and I want to challenge you to do some. I want to challenge you to do the same. This requires an incredible attention to detail, not only when you are planning, but when you are delivering and you are in the middle of surgery. So let's talk about my flow. So patient calls up, patient comes into your office, whatever this may be, the normal routine, and patient says, I want to talk about full arch care. My teeth are a mess. I just got over an eating disorder or social drug disorder. Someone left me money, whatever the case may be. How do we begin this, right? So step one for me is always the initial meeting. Now keep in mind that when you begin to do this as your meat and potatoes of your practice, I do this on Tuesdays and Thursdays, and I see all my post-ops and new patients on Wednesdays. You begin to understand the process of how the guides go in, how things need to be designed. The part that changes are the people, the shapes, and the colors, right? But just like driving to work, you get in the car, you shut the door, you turn the ignition on, you go in reverse, and then you go forward. It doesn't matter if you're in a Ford or a Ferrari, right? That's how you do this. So the reason I'm mentioning this to you is because at my step one, my initial meeting, at this point in my career, I'm interviewing the patient, and the patient doesn't even know it. Because in that mind, in that mouth, is a lot more detail and a lot more of a deep story than I'll ever know. And when you take these cases on, I promise you, you have to understand that you're married to these people. And so you better make sure that when you meet these people, that you want to be married to them, because you will be. The big check is good. It's wonderful when you deposit it. That's a wonderful thing. But that's when the tough gets going. So the first thing that I'm doing in my step one initial meeting is I'm doing an interview. They don't know it. It's just through dialogue, very basic dialogue that I'm going to share with you. And I do what's called a Scout CBCT, and I'll explain what that is in a minute. And then what I'm going to do is I'm going to basically present some generalized care and how I do that. Now, keep in mind that 90% of my practice, is full arch. And I say that because that could consist of removing teeth, grafting, and providing someone with just dentures, which I happen to not do. Or it could be some type of tooth removal and implant over dentures, which is a wonderful, wonderful option. And then, of course, the fixed option. So it's typically one of those three. And if they choose the denture, then I'm going to refer them somewhere. But the reason that I say this is because a lot of those decisions have to do with time, fear, finances, and we'll walk through that as well. Step number three is when I'm going ahead and I'm going to, once they have alluded to the treatment that they want, they've accepted the care and they understand everything that's involved, the number of visits, the time per visit, the finances, the diets, etc., which I will go through as well as I can in an hour and 15 minutes. That's when it's work time. So at this point, what I'm going to do is I'm going to gather all the data and I'm going to transfer all the data. Again, I'm going to share that with you, and I'm going to make it sound pretty straightforward, and it can be. But I want you to always look at the devil in the detail. And it's just no different than a crown prep and a nice, really nice impression versus an okay impression, right? Step number 4 is going to be designing this incredible stack of guides that bring you from A to Z. And it's really amazing. 95+% of the cases that I do guided. And we're going to talk about that as well. Can you do freehand? Of course you can. Can I do freehand? Of course I can. The main reason that I do guided is not to make me a dentist who can achieve things without thinking through it. It's not to replace intellect. It's not to replace knowledge. It's not to cover up from what I don't know. This is absolutely not it. What it is, it's the ability for me to have prosthetic control. Now, the argument might be from an oral surgeon or from a bona fide GP who does this, well, I can control my prosthetics. I don't need to do everything guided. And I'm not saying that you can't. And I know a lot of people that like to do freehand, and that's wonderful. I'm going to share some other benefits with you that play into guided surgery as well, other than just being able to line up the prosthetics. Then lastly, of course, it's executing the care. All right, so here we go. Benefits of guided surgery. All right, so number one, it can be, can be reliable. Number two, can be very accurate. I'm here to tell you this is true. Number three, it can be very time efficient. Next, can be very stress reducing, not only to the patient, but to the clinician. Take a minute and think of the last time that you were in knee deep into something, struggling with something that you typically don't struggle with. What was your demeanor? What was your personality? What was your patience? How do you feel you acted, right? Does that help the outcome? Does that help you calm and do the artwork that you should be doing when you are free in your mind? That's another question for you to answer. Definitely can give you more surgical control. And notice how I'm saying can, because the flip side of can is may not. This has a lot to do with the information that you provide into the software to then design the case to get these stackable guides that give you what you dream of. And this is something that we take a lot of pride and a lot of care in. And you remember, just like a dental lab, it's you know, they always say poop in, poop out. And it's no different here. It starts and ends with us. Number 6, prosthetic control. For sure, I'll show you some cases, a couple cases where if I show you the occlusal table of the prosthesis, you'll swear that the canine implants were flared to facial, and they're not. So if you were going to do a case like that, you would absolutely assume that these implants should be brought palatal, which would be incorrect. I'll show that to you in a few minutes here. Assistance in wound healing. We know that after surgery, during surgery, the way that the tissue is handled, the way that the tissue is maintained during surgery, how long the surgery takes is directly proportional to how the patient heals and how the patient recovers. There's no question. Are you irrigating your flaps regularly during surgery? Are they getting dry? Do you find that the patient is running through anesthetic? Okay. Do you find that you have a lot of bleeding? Are you having trouble maintaining saliva control? All of these things help with time. Time makes this easier. And when we talk about wound healing, we all know that the shorter the surgical time and the more care that we give to the tissues, the better the patient's experience is going to be. Surgical growth. Now, when I say surgical growth, I'm talking about yours, mine. When we put these cases together, and I walk through some of these cases with you, the detail at which you build these cases demands you to learn. Do you know exactly where the mental foramen is? Can you dissect the mental foramen? Do you know where the nasopalatine is? Can you dissect that out comfortably and work around it without being nervous? And here's the thing, if you know where it is and you're aware of it, it's not going to make you nervous. Let's talk about a freeway. Driving 80 miles an hour on the freeway. You're in the fast lane. America, it's the left lane. What's on the opposite side of the freeway? Somebody coming at you the opposite direction. Are you worried about that person? No, because you know that that person's going in one direction, you're going in the other direction. It's the growth and understanding of these things that calm you. When you know where something is and how it won't harm you, you're going to feel more free as a surgeon to work around this. But it takes sheer dedication to understanding things like anatomy. Now, here is what I feel is the biggest underdog, is the biggest undervalued portion of guided surgery. You're hearing it from me, you're hearing it right here. And that is the ability to have the patient buy into their care live, okay? This is something that without question has become an art in my practice. And I'm very, very proud to say, believe it or not, I would not tell you if it wasn't true, that yesterday, presenting these cases, I personally closed 10 arches of fixed hybrids in one day, which was my personal record. And if you were to ask me how, this is mind-blowing. To me, it is. Before yesterday, I think my record was 5. 10 arches. How did I do it? Well, I didn't show them that I could put an implant in straight. I didn't tell them how I graft. I got involved with them in their care, and I showed them their care. And we're going to talk about how to do that. So through this whole thing, when you bend your brain about anatomy and you bend your brain about what the guides are called or how Engel would do it or where is the nerve or whatever, I want you to really hold true that bringing the patients into their treatment is far more beneficial than anything I can tell you to do. They have a buy-in. Give you an example. You and your significant other decide that you want to go to Europe or you want to go to Manhattan or you want to go to somewhere in the world and you want to buy your first home away from home. What are you typically sold on? Well, I have purchased things before at dirt level based on a rendering. So what you're looking at here on the top is a rendering. And you are buying into potential. And you're buying into a rendering, a virtual idea of what is on the bottom. And now you live there, right? Or you and your significant other feel maybe you want to design a room in the house. You hire a designer. Designer has a virtual idea, which is on your left, and you buy in. And then on the right, this dream comes true. So what I'm getting at is you're buying into virtual and not even understanding what reality is. And the benefit for us is that we actually start with reality. It might not be a good one. In most cases, it's not if you're prescribing full arch care, but it's reality, which gives us an advantage because we can show them that things aren't very good. Buying what will be in terms of real estate on a piece of dirt, there's nothing really negative about that as long as the rendering makes sense to me. There is something negative about oral decline. Okay, this last example, let's take this example. You decide that you're staying right where you are and you are going to redo your home. You hire an architect, you're looking for a builder, and you decide that you are going to start with concept. Does this sound familiar? It should. You're gonna start with concept, you're gonna initiate the workflow, and then you're gonna complete it. So essentially, this is the one right here, virtual to reality. The one that actually captures you is the concept. Because if it wasn't for the concept, you wouldn't take on the architect, you wouldn't take off on the builder, and you wouldn't have what you're staring at on your right, which you now love to live in. So you bought into potential based on virtual. Okay, I saw this today. I saw this today, 3 hours ago, on, I believe it was Yahoo or Google. Are virtual renovation photos an effective tool to sell homes? So you have on the left something that needs some help. On the right, you have an artist rendering. And they're asking, can we sell potential based on not knowing what we have, but trusting a drawing? And then the person moves into their home. And the question is, can we deliver that reality that we draw? Let's take Brent. Let's go to the dental world of virtual and reality. And I'm telling you that I feel that when I attempt to achieve a surgery and I attempt to achieve prosthetics for that surgery, the tenure that I've had in this business typically gets me where I want. But I will tell you that it all starts with the interaction with the patient. The patient has to know you care. The patient has to believe in your intellect and your ability to do the care. And you must involve the patient in what the virtual plan is. So here's Brent. Now, my question to you, Brent has a professional one is called a spectrum disorder, autism. My question to you is, if Brent walked in your office, would you give him the time of the day? If he couldn't speak the right way, if he was, if he had if he was disabled, what would this mean? Okay. Well, I sat down with him and I treated him just like every other patient. And what I did with him was I explained that his reality was meek. His reality was something that there was not a lot of choices here. And I involved him in the virtual idea of what I wanted to do. I felt that for him, based on Asperger's and some of the other things that he deals with, that something fixed would be better for him. And I showed him what he could have. Brent, this is you. This is reality. Here's a mirror. So he saw what you see. Brent, here's the virtual world that I want to bring you to. Well, this was right after surgery. So Brent understood his reality. And Brent listened to me when I brought him to his virtual. And then I brought that to reality. So if you think about it, you get this patient that comes in, maybe you would give him the time of the day, maybe you wouldn't, maybe you think he had no money or didn't want to do it or whatever. This involved his parents, and they had plenty of money, and he understood what he was at. His parents understood. So maybe not every one of your patients is like Brent. Okay, maybe your patients come in and they're business people who make their own decisions, whatever. What I'm getting at is the people sitting in your chair don't understand dentistry. The people in your chair, if told right and if engaged in their own care, will buy into the potential of what they could have. And it's merely how you present it. Okay, so again, as we look at the benefits of surgery, and I'll pause here, and I want you to look at some of those. And I want to ask you, like, for you to think about what on there, if you have done guided surgery or you want to do guided surgery or you're just dabbling in surgery, what on there do you find as a benefit? What do you see? For me, it's the patient care, it's time in and out of chair, it's the expedition of the case, something that could take 4 or 5 hours easily if it's done freehand and turned over and converted. I typically take about 1 hour and 45 minutes, and we're screwing in temporaries. And this, don't get me wrong, this takes a lot of practice, and I'm not boasting, I'm just saying that's how long it takes me. I think if I were to do something freehand, I could probably add a couple hours to that, half in surgery and half in prosthetics, trying to align everything up. Okay, don't lose sight of the involvement in care. And you should tell them, hey, Brent, I want to involve you in this care. They'll buy in. Okay, so that being said, I do want to mention that there are 2 very complex parts to this. We are 8 years ago, 10 years ago, 11 years ago, nobody but the specialists typically did these. And why? The reason is because you have to have a really good, deep understanding of not only everything surgically, but everything prosthetically. And that's why a lot of cases are started by surgeons and completed by either themselves or a GP, because there is a line in the sand where a typical GP doesn't have that surgical intellect of somebody that might have went to school for 4 or 6 extra years. So as I go through this, I told you I would say it again. I do not want to make light, or I do not want to make this sound like it's something simple and it's something that should be done, before lunch, and it's very simple, and as long as you have guides, you're good. No, I am able to control anything that I do with complications, with intrasurgical complications, post-surgical complications. The fact that I do guided surgery is merely a choice to execute the care. So today we're going to focus on the surgery in the short hour and whatever we have left. I will dabble in prosthetics. And the reason I'm telling you that is because dabbling live and dabbling during design won't do it. So this is just to get you started, to get your whistle moist, and to just involve you in my world and hopefully yours. Okay, so we're going to be doing the surgical part today. All right. As I mentioned here, a clear understanding of all core steps and principles are paramount. Paramount. Okay, so if you're a specialist, if you're a GP, no matter who you are, I'm telling you, from me to you, the intellect of surgery and the intellect of prosthetics needs to be elevated to be in this game successfully. And that's the best advice I can give you, so keep going. So I call this the Uber of dental, and I use this example. Here's where my office is, Center Lake Drive, and here's the airport. And if I type in where I'm at, and I type in where I'm going to get an Uber car. If I don't type in where I'm going, Uber won't even know I exist. So I call this full mouth reconstruction that we're going to share with you tonight something similar to Uber. We need to know where we are right now today. Think about Brent. And we need to know or have a really good idea as to what do we see, Brent, at the end before we start. And then all the pink dots can be filled in along the way. And I'm going to help you with that. Okay, on we go. So patient comes in, CBT scout. Meet Tim. Tim comes in, and I'm not going to spend a lot of time diagnosing everything you see. Most of you are dentists, if not all of you, you see everything. You see the wear patterns, you see the partials, you see all that. This is merely the discussion with Tim going to that interview, okay? Hey, Tim, how are you doing? I'm Dr. Engel. Thank you so much for coming in today. We're going to get some preliminary information. I'll be back shortly. I just wanted to come and say hi and welcome you to the practice. From there, we're going to do what's called the Scout CBCT. And what that is just a quick CBCT. And it's going to give me a general deep dive view to indicate to me what is actually possible, okay? So he takes his CBCT, this is the Scout view, and I say Scout view, it's a regular view, I just call it a Scout view because I'm blazing through it. So here we see in the patient's lower right, number 20 position, and we have plenty of width in the number 20 position. And I always look at it like, can I do fixed? I did a global lecture a couple weeks ago with Strawman, and we were talking about clinical decision making. If you caught that, it was great, and thank you. If you haven't, go to the Strawman website. They have it recorded. It was wonderful. It was, how do we make decisions once the patients are in our chair? What is our workflow? And one of the things that I said was, regardless of health history, regardless of money, regardless of time or fear, any of the things that prevent patients from doing treatment with us, which we all know, I want you to sit down and I want you to look at the CBCT and just take 30 seconds to a minute, minute and a half, and in your mind, come up with the best possible thing that they can do. And then you address some of the issues that might be present, like the money, like the health history and stuff. But what would you do with this patient if the best thing could be done? And for me, it's always a fixed zirconia bridge or a fixed hybrid or something like this. So my initial go-to is I like placing 5 implants on the bottom. That's my go-to. And I like placing 6 on the top. So typically my posterior implants are going to be in this, somewhere in the second bicuspid area. So I start second bi, I roll around to the other side second bi, and I see relatively quick if I can get 5 implants in that are spaced somewhat equally apart. Here we go. So here's number 22, moving right along. It's typically every 2 teeth, plenty of width there. For an average size 4.5 millimeter Strawman implant. Here's number 24, no problem, 4.1 millimeter Strawman implant. And I'm not designing anything, okay? So the depths, I'm not placing them at a certain depth or a certain prosthetic position. I'm just looking at what they look like in bone. What does the bone look like, right? And then here would be implant number 4, around the corner, the number 26 position, plenty of width. And then lastly, number 28. And here we are in the number 28 position, plenty of width. Now, one thing I would like to share with you at this point, you see the cortical plate, okay, which obviously is the white opacity outline. Now, when you look at a case in cross-section, we're looking at a sagittal view on your right. I want you to try, if you can, to measure from internal aspect of cortical plate on the facial to internal aspect of cortical plate on the lingual. And the reason for that is because, as you see in this image, the black and white kind of fuzzy center, that's the nutrition. That's where all the medullary spaces are. That's where all the blood supply is. That really is what's going to integrate your implant and turn it over to secondary healing. The cortical plate, you should think of it more like a protective plate, not necessarily a plate of width that will provide a blood supply. And this is why I caution everybody to be really careful on ridges that are narrow, because if you're counting the cortical plate as width and you're getting down to 6 or 5.5 millimeters, you really only have 3.5 to 4 millimeters of good cancellous tissue with medullary spaces and blood. And again, don't forget, you cut a hole out to put the implant in. So something to consider. So as you look at this, this patient had tori, which we ended up removing in this. Also, we do not count tori as width. So if you look at this and go, wow, I have 20 millimeters in width, this is not true. This is, you got to look at this as something like a condensing osteitis where there really isn't any blood supply in there. There is width, so don't be falsely happy that you have a ton of width, because you can't count on the tori to provide good nutrition and a good blood supply to the implant. Anyway, moving right along. I go in and I'm thinking in my head, okay, great. I could do a fixed prosthesis. If I hear that money is short or there's an issue there, we can certainly drop down and do a 4-implant overdenture, or whatever it may be. But we want to start at the top and work our way down in terms of design. Not necessarily always in the presentation style, but in design. Hey, Tim, great news. I want to present you with a good, better, best scenario. And if you've ever seen me before, you've seen this on every lecture. Why? Because we know that humans are attracted to things in 3. Look at Starbucks, look at a number of things, the way people tell jokes, the punchline's always on the 3rd delivery. It is very well known that we appreciate and are attracted to things in 3s. If you give someone a this or that option, they don't like it, they feel trapped. Beyond 3, especially in the dental office, they become confused. So I am going to give him 3 options, and psychologically, he loves that without even knowing it. So Tim, here's the good, better, best. If you plan to do reconstruction and remove teeth, we can offer you something where you have tooth replacement with a traditional denture. And if you choose that option, I actually don't do them here. I would refer you out. And the reason is I don't typically see people for a long period of time that are happy with dentures. And my schedule, quite frankly, doesn't accommodate that. And I don't want to make people upset with the treatment or me as it relates to the treatment. Tim, let's go on to better. The next best thing would be something that you do remove, take in and out of your mouth. And we do support that with implants. So you have a vertical retention and you have a horizontal retention. So about 70 to 80% of the things that you want to eat, you're going to be able to eat and eat well. You don't have to sleep with them. You can sleep with them. They come in and out at least twice a day to clean. And we go through the maintenance of that. Or Tim, you can go to the next best thing, which is the best thing in my opinion, something that doesn't come in and out. And we can talk about that as well. The main difference obviously is budget. And I realize that dentistry can get costly. Quite frankly, the higher you go, the more it costs me to do the dentistry. So I get it, Tim. Tim, can I ask you, and guys, if you're watching this, the next couple of things that I'm giving you are massive, massive breakthrough questions. So please write this down. Tim, am I the first person that you've spoken to about this? And if he says yes, I zip and I listen, because he's going to tell me a lot. Maybe he's going to tell me that the last guy was too expensive. Maybe he's going to tell me that the last girl wanted to do implant overdentures. He got up and walked out. Whatever. Those are all the clues that are going to help me give Tim what it is that he's looking to hear. Next thing, what do you think you need, Tim? Do you have any idea? I always ask people that, because even though I might feel, or you might feel, that all the teeth obviously need to come out, they might not think so. And if you tell them and they're not braced for that, you can really offend somebody. So, hey, Tim, what do you think that you need now that I'm your second visit? What is it that you think you need? And by the way, Tim, if I am your second or third stop, what happened in the first 2 stops? And listen, they will tell you. Next, Tim, I want you to look at this new smile like an apartment versus a condo versus a home. And, you know, proportional to what you invest, your treatment can go up as well. And lastly, most people don't own their homes, Tim. Most people don't own their cars, Tim. So I want you to understand that a smile and the ability to eat, the ability to have self-esteem and go in the workplace and have a relationship and be intimate with someone, and all of those things that the humans love to do, teeth are important. In fact, I think that they are as important as a car. So maybe you want to consider making a monthly payment to have that beautiful smile. And these are the things that I talk to the patient initially. I am not telling them, hey, I'm glad you found me, Ben, because I'm the guy. And now that you're here, I'm really happy you chose me, because I'm going to get this done correctly. Okay. It's none of that. They want to know that you can get into them. They want to know that you can understand them as human beings. So Tim says, hey, Dr. Engel, listen, I'm a chef. I deal with people all day long. Oh, that's awesome, right? And I refuse to take my teeth in and out. Now, what I'm hearing is money doesn't matter. He's been to a couple people. He's probably heard something about money. And so he's telling me, no, I'm not taking my teeth in and out. And he says, hey, can I finance this care? So Tim says, I want a hybrid. I want something that's going to stay in. And as Tim's talking to me, I'm going through that interview and I'm looking here. What do you see here? Pupil alignment, Are they out of alignment? If you were going to do veneers or you were going to do, 8 crowns across the front, how would you design them? Would you design them to the pupils of his eyes? But they're crooked, right? What would you do? And we'll talk about that. And I look at his smile, right? My question is, do you think that smile is going to change? I know it will change, because what you're looking at right now is a smile from someone who has no self-confidence. Okay. Now, as I give you pearls, you need to take a couple of notes, and I don't mean you need to. I'm not trying to be demanding. One of the most important things that you need to look at in a patient is the smile line. Where does that lip line up? And I guarantee you 100%, when you're done and you've delivered this beautiful smile, that will not be there. And why do I tell you this? Because there's also something called a transition line. And the transition line, is where fake meets real. So if they decide that they love their smile and that lip moves up 7 millimeters or 6 millimeters, and you haven't accounted for that, there's a lot of trouble. So these are some of the things we're going to talk about. Okay. All right. Tim elects to go with a full arch zirconia bridge. Great. So we did the scout view. We went in there and said, hey, Tim, guess what? After I walked through in my office under, looking at my CBCT, I went in there and I said, hey, we could pretty much do whatever you want. Well, Dr. Engel, I'm not taking my teeth out. I deal with people. No, that's not happening. Okay, great. All right. So for the purposes of tonight and the purposes of time, let's assume that all of the financing happened. I can't remember how he financed it, whatever he did, but let's just assume off we go. Okay. So step 3, now that Tim said, I'm doing it, I don't care what it takes, I'll find the money. And by the way, people will find money for something that they want. This is true, okay? There are a lot of people that drive very expensive cars that can't afford the apartment that they live in. And that's just the way it is. If you want it, you will find money for it. So let's go now to the guts of guided surgery, okay? And I'm gonna be very, very mindful of time as well. Let's gather the data. Let's look at how do we do this, right? I wish I knew who was on this meeting. I know that there's people all over the world, and thank you so much for staying up until 1 and 2 in the morning if you're in Asia or Egypt or wherever you are. Thank you. But how do we do this, right? So let's walk through that, gathering the data. Okay, so when I started doing full arch guided surgery about 17 years ago, it was daunting. You had to buy your own surgical software, you had to design your own cases. A lot of it was only being done in Europe, so the language barrier and the time barrier, it was really very difficult. And you needed 3 to 4 scans to complete this, and it was quite expensive. The way that we have morphed into what it is today has made it really just so much more feasible for everybody. And I'm really excited about this. I can say that this in itself, what you're going to look at for the rest of the evening, is probably what keeps me really excited about dentistry, this very thing. So let's talk about the data acquisition. For the rest of today and until maybe sometime down the road, the next 5 years where it changes, we're going to refer to this as a dual scan protocol. And what I mean by that is we need 2 general scans. Okay, so let's look at this. One is the DICOM scan. The DICOM scan is the black and white. 2 is the STL file, or the stereolithography file. Now, the thing about this is the stereolithography file that I'm going to show you how we achieve this. Ultimately, if you take anything away from this, if you're a beginner or you're getting started, this has to be something that has the potential to be the ultimate design plan, whether it's a fabricated denture or whatever the ultimate desire is, or maybe a virtual wax up. But nevertheless, let's walk through. Let's start with the DICOM file. So the DICOM file is, or DICOM set, is a set of files ranging from about 325 slices to about 515 slices, depending on what kind of machine you have, what settings you have, etc. A DICOM slice is just one cross section. Okay. DICOM stands for Digital Imaging Communication of Medicine, .DCM. Okay. What is this used for? A DICOM file is basically used for placing implants safely in a jaw. So you can see right here, right? I'm not worried too much about the angulation. This is just for purposes of explaining to you. How does this all get done? Well, there's two components. One is the black and white component, which houses the implants. So when we virtually design the implants, the place, the position, the diameter, the angulation, the depth, all of that stuff, that is designed strategically on the DICOM file, okay? So that allows us to see things in 3D, like you see here. On your left, the axial view, the patient's laying in the chair, looking at the ceiling. On the center view, the coronal view, the patient's in your chair, looking right at you, like I'm looking at you now. And then the sagittal view, of course, which is the view that we most often use in this field for placing dental implants, is patient looking to the right or left, and us looking at the cross-section or the thickness of the jaw. And when patients balk at taking the CBCT, we tell them, imagine a loaf of bread, and you see all the slices from the side and it's brown. When you turn the loaf to the side or open up a slice, you see the white part. That's the part that I need to see to keep you safe. And that's how I explain it to them. I put it in their terms. Okay, so DICOM file, .dcm, that is one file, and that is used to ultimately show us where we could safely place implants. Okay, let's go to the next file. The next file is a stereolithography file, used in medicine, used in art, used in music, used in movies. If you saw Ants, if you saw Toy Story, any of these, this file is used in all of that. And we use it in dentistry and have for years. The STL file is captured a number of ways. And after lecturing and speaking and teaching this all over the world for the last 15 years, most people now are getting into some form of an iOS, an intraoral scanner. And most people are getting their files from that. It's a couple-minute scan, you do the maxilla, you do the mandible, you do the bite, and off it goes, virtually right from that little computer that you see there. So if you have, a CERAC, or if you have a Trios or an iTero or any of those, you're very well used to it. If you are not in that game yet, no problem. We can still help you out here. We can just do a good old-fashioned impression. I love this material that you see here. It's called Silginate. It's by a company called Kettenbach. Kettenbach USA. You can contact them directly. You can even tell them that you saw the webinar and they discount product for all of my sessions. I'm not vested in any of that either, as I'm bringing it up. Again, this is called Silginate, and it is a PBS, and it does a wonderful job. And then what will happen is that you can next day this or two-day this to 3D diagnostics, and they'll use some type of very extravagant scanner, an optical scanner, what have you. And from your impression, they can produce the virtual model that you see on your lower right. Now, what does the STL file do, you might ask? Well, two things. One, guide fabrication. So if I'm going to sit something on teeth, watch the occlusal tables of the teeth, okay? That yellow line picks up the anatomy of the dentition. So when I fabricate the guide, as you see here on your lower right and lower left, we have a perfectly fitting guide, and that is based on the anatomical presence of the teeth conveyed through the STL file, okay? So how does this come together? Well, remember, black and white, we place implants safely. Colored, or STL, or physical, is where we're going to see our guide on, like you would make like a night guard, etc. So what else is a good use for an STL file? Well, something called Emerge. So this is actually the file that is going to help dictate prosthetics. If I could design something in black and white that's very safe, and I can orient it, having an STL file that shows me ideal prosthetics, this is the perfect world. Well, this is what we call file merge. Welcome to guided surgery. Whether it's one, multiple, half arch, full arch, this is the name of the game. So what happens when we merge? Well, you're not merging, you're sending two files over. Someone like 3D Diagnostics, and I'm going to say this many times, I've used 3 guide companies throughout my guided career for 17 years. And I've never felt like I've had such consistency, precision, and care as I have over the last 6 or 7 years with 3D Diagnostics. And I'm not paid to say that. I'm just telling you because of my success with not only them, but with the guides. Back to this. Let's look at how 1, 2, and 3 come together in the DICOM file and the 2 reasons that we're going to use an STL file. Notice the yellow circle. That is what? You might ask yourself or tell yourself, if you're a veteran, you know that's the implant placed safely in the DICOM file cross section. Well, how do we know if that's in the right position? Well, now we do, because the other part of this, the second part of the STL benefit, is that we can see where the prosthetics will be. So here, for instance, if I do a denture, or if we do a virtual wax up, or if I have adjacent teeth, something that indicates to me where this tooth that is missing will eventually go in, then I can combine them, and this is called a merge. Now you see a big yellow circle. Let me get my power on. My computer is warning me that I am going to run out of power. I apologize. There we go. Okay. Sorry about that. All right. So what you see now with the big yellow circle is you see the combination or the merge of two files. So when I'm talking merge, I'm saying you take this and you take this and you marry them and you make it one. So now this big yellow circle, if you're new to guided surgery, what this shows us is, well, fantastic. So that's where the tooth proposed to be, or teeth, right? If you do a denture setup, let's say on an edentulous patient, and you see where all the teeth need to go. Now you see, you have the benefit of seeing where the teeth need to be, right? And you have the benefit of seeing where the implant is safe, and you combine them. So you're working all in one spot to accommodate the future needs of the whole project, right? And this is when we can take it, maybe tip the platform towards the palatal, or maybe tip it towards the facial, or look at this and say, well, I need a custom abutment. Will I need a screw retained angled abutment? What will I need? So we're going to close out on this part, okay? But basically what I'm trying to explain to you is you have a DICOM file for what you see here in black and white. You have an STL file that will help for guide fabrication to fit correctly on the jaw, and it also will help you in prosthetic design as you're placing your implants. Okay, great. This solidifies the final implant position. So let's just say I was doing 2, 3, or 13, or 14, whatever this case may be. This case is now ready. Excellent, I'm ready to go. And this is a 10-minute procedure for me. Get the patient numb, put in the guide, punch the tissue, 2 or 3 drills, and the implant goes in. It really is that quick. Okay, so this is where the merging takes place. This is the part that 3D Diagnostics would do. They would take the STL file, they would take the DICOM file, they would merge them together, putting them in the software. I use a software that's the most widely used actually guided software in the world, and it's called Co-Diagnostics. It doesn't mean you have to. There are several different designing platforms, and Co-Diagnostics uses many of them. And also implant dependent. I happen to be a Straumann guy. If you are placing another implant silhouette, they have all of the libraries for all of it. So I'm just speaking about Co-Diagnostics and Straumann because that's my menu. It's what I do. It's what I use. It's what's very successful for me. So I stick with that. But if you have a different combination, that's not a problem. Okay, so let's talk about this now. Partially edentulous, very easy. So what I want you to do as I'm showing this to you, so we have a really good understanding, is I want you to look at the lower left, okay, the panel view, and I want you to look at the line right here, okay? I'm gonna go back, and I'm gonna do that again. So the red line between 8 and 9, can you see that? Okay, so the red line that I just made yellow between 8 and 9 tells me that right here, that's what my width is. I can see the nasopalatine, everything is right there. And when I look at this, I have teeth. So if I go to the mouth and I look between 8 and 9, okay, or 1, 1, and 2, 1, if you're watching from a different country, I know that that right there is between the teeth. So the teeth are essentially markers for me, right? Or if I take out a canine, I know that the cross section of the canine is the canine in the bone, and I know after I take the canine out exactly what I'll have because I'm looking at the canine. So the question is this is all well and good in partially edentulous patients or patients missing just a few teeth. That's well and good and simple, right? But what do we do in a case like this, which is most of our full arch cases, right? What does this mean? I don't know. Does this mean that it's in number 9? Does it mean that it's in 2-1 if you're watching in a different country? Is it right in the center? Is the center under the nose? If that is in the number 9 position, Is the denture tooth that's centered correctly in the patient's mouth over that spot? We don't know. Why? Because it's not connected to the human. So if you imagine this on an edentulous patient who's lost a lot of bone, and you make a beautiful denture, and it makes it look very natural, like they never lost bone, they never lost gums, they never lost teeth. They smile, it looks fantastic. But when they take it out, they've lost all of this bone. So how does bone resort? On the top, it resorts up and inward, right? So the canine eminence is definitely not going to be under the actual canine on the denture. So how can we articulate teeth that aren't in the patient's head? Well, in comes a different type of a scan. And we're going to talk about using the denture and putting radiographic beads on it or glass markers. Very simple to do. And we're going to do the same 2 scans. So as I talk about this, which will be fairly quick, the one caveat here that I didn't have written down, but I wanted to remember to tell you, is you must do a soft liner immediately before you attempt what I'm going to show you. You have to have the entire intaglio surface of the denture in communication with the soft tissue on the roof of the mouth and everywhere around the jaw. This is going to mimic how the guide fits, because this is now going to be a soft tissue guide because there's no teeth. So if you want to avoid rocking, which is a big problem, if anything rocks, do not use it, okay? Because you may be right, you may be wrong. It may be something in the middle. It could be catastrophic if you're near sinuses and nerves. So how do we get something to fit really well on a patient who doesn't have teeth to support us? And what we find is that with the 3D diagnostics technology, I have found that I don't even ever remember sending a guide back that was a soft tissue guide that rocked, ever. Why? Because I make sure that the soft line is a fresh soft line and intimately touches the tissue throughout the top jaw. Okay, so imagine you put this denture in and you got this brand new suction in there and everything is fitting. What we're going to do now is we're going to put the denture in the patient's mouth with these beads, and I'm going to show you why. Okay, now what you're looking at right now is it's not confusing at all. It may appear confusing, so stay with me here and I think it'll make a lot of sense. There are 2 different scans, okay? Just like a patient who has teeth. We do an STL intraoral scan of their teeth, and then we do a DICOM file, a CBCT, and off they go, and they merge the 2 files. We're going to do 2 files on these people as well who don't have teeth, as you see here. One file is going to be the DICOM file, but because they don't have teeth, we need them to wear teeth that fit, wear teeth that you plan to ultimately have in that prosthetic position, ready to go. Okay, so on the top, what you're looking at is you're looking at the patient wearing the denture that fits really, really well. And it has 3 external beads on the facial, 3 internal glass beads on the palatal. These are 1 millimeter beads that are spherical, and they don't change shape. I apologize about the hiccup. The patient, this is a brand new scan, and the patient, it bumped their shoulder, but I really liked how the scan looked for tonight, so I threw it in there. Anyway, if you look at just the top scan, that's the DICOM file. Okay, they just happen to be wearing plastic teeth. Now, if you look at the cross section in red, you can see the cross section, you can see the tissue, you can see a faint white line, which is the soft liner. 3D Diagnostics has the technology to know where that liner is, because when they make you a guide, they know what is soft liner and they know where gum begins. So there won't be a gap in your guide. Okay, right under that tissue, or in this case, the denture, notice on the top you see that bead. There's 1 bead. There's 1 bead in the red cross section. Okay, and that bead is corresponding to that green square with the red line going down. All right. Now from your right, if you count with me, that is the 2nd bead over. Okay, so that 2nd bead over on the bottom, the next scan is going to be the denture by itself with those very same beads. And what we're going to do is we're going to take the 2 scans and we're going to merge them. Now I'm going to go back and I want you to watch this again. I'm going to merge them. Watch the 2 beads, the bead on the top in the cross section and the bead on the bottom in the cross section. We superimpose them, or I should say 3D Diagnostics superimposes them. Wow, how incredible. So there is a tooth there. I know what tooth it is because the bead's right there. And what this is now telling me is there's the bone on that tooth, and here's the prosthetic angulation at that spot. So when I go to design my cases, Dr. Epps helps me. Thank you, Dr. Epps, who's probably listening. We know that I should plan for a 17-degree abutment here. No problem. No problem at all. So again, what this is doing here is it's taking something that is static called a fiducial marker, putting it on the human that doesn't have teeth, putting it on the denture, and merging them together to go, okay, well, if this bead is by the canine, that's what I now have at the canine. If this is confusing, jump on 3D Diagnostics website, which I'll give you in a little while, and have a look at it, call over there and ask them to explain it to you. But it's marvelous. And it shows us where the bone is underneath the tooth that is being worn in the patient's head in the position that it actually needs to be in, as opposed to where the bone might be. Okay? All right. So again, we're going to do one file with the patient wearing the denture. We're going to do another file with the denture by itself. Okay? And this is what I see in cross-section. Awesome. So when I get to the canine position, I know this is the canine. Okay? It gets a little bit wider as I go distal to the canine, but I can't go distal because I need an implant over the canine in this spot. So this is the outline of the bone. This is the outline of the tooth. I plan my position of my implant, and it's going right into the cingulum of my canine. Now, that is awesome. Okay, so when we talk about time, when we talk about learning surgical intellect, when we talk about the expedition or how quick the surgery goes, there's not a lot of wiggle room here, as you can see. So this is just one of the many benefits. You can see the beads there in the cross section. Okay, one little take home, and again, all of this, not these photos, but this information is on the 3D Diagnostics website, 3ddx.com. One of the things you want to do on your second scan, which will be your STL file, is you want to, when you scan your denture, you want to make sure that it's not sitting on the plate of your scanning device. You want to make sure that it's lifted off of something that is radiolucent. And the reason for that is because if you don't, the edges of the teeth will disappear into the metal that's in that base. And then they will have problems merging the files because they actually merge two files together by incisal edges of teeth. So if you don't have a CBCT scan, you could send your patient to the lab. Every lab in the world now just about does these, or there's a lot of mobile companies that come to you as well. So let's look at a case. Okay, so patient upper left comes in, has, edentalism, was wearing a denture. I'll walk you through this case. Just absolutely miserable. Just a wonderful woman, but just her life just caved in front of her. And as you see here, if you just look wherever, you could see that I had a PMMA pre-made, and then the surgery happened and it was placed in. And my gosh, this is great. Her midline was off, but we on the lower teeth, but on the top teeth, we made it right under her nose, even with her face. So you'll see really pretty smile. But the point I want to bring out here is if you look to the lower right, look at the canine. Look at the canine on your left as you're looking occlusally. Wow, that implant is just so far facial. Is it? Is it? Well, I don't think so, because nothing was patched on any of the other teeth, right? So the point that I'm bringing up is that sometimes when you do freehand, you can be fooled by where bone is, right? If I would have put it where bone is, I might have had a big problem prosthetically, getting to the screw, repairing the tooth, having an access opening aesthetically outside the tooth that was just impossible to blend. So what you see here, when you look occlusally, you go, wow, it would have been really nice if they were nice and round like picket fences. I totally agree with you, but that's not where it needed to be. And that's what the merging of these files do. And I will have you know that when I delivered this temporary to this gal, there wasn't one adjustment, okay? All the teeth that you see are whole and intact, and everything is through the palatal. This is a dream for me, right? Could I have done this freehand? Maybe, probably, but why, right? Okay. So what I'm going to show you here is at the top is how I met her, and at the bottom is her 5-year post-op hybrid. Now this is Tony. Bobby. I met Bobby probably about 6 or 7 years ago. She came in day one. When we talked about the midline, she was wearing a denture, hated her denture, didn't stay in, couldn't eat. Now, if you look at the midline on 8 and 9 or 1, 1 and 2, 1, it's totally off of her nose. Someone lined it up with the lower teeth, which was incorrect, right? So day one, look at her face, look at her eyes, look at her, how defeated she looks, okay? This is at the time of me delivering her PMMA, okay? Just look at her. I mean, she has a whole new look about her. Her cheekbones are raised. She feels good about herself. She's happy to be alive. She made herself up, right? And here she is at year 5. And you can look at her midline and she looks fantastic. And this lady is a completely new lady. I mean, she comes in, she's wearing a color blended outfit with a scarf around her neck. She's had her hair done and she wears lipstick now. And to me, I will never be able to be paid for that, right? Money can't replace that. And the fact that I could look at her now, which is 5 or 6 years now, and still look at what my artwork, and just be honest, my artwork and my skill set gave this woman, I can't put it into words. I just can't. And this for me is why I do what I do. So just real quick as we end this, these are 1mm beads. There's a reason for that. They come in many different sizes. 1mm beads are used for guided surgery. And you actually can get a box of these from 3D Diagnostics, not very expensive. Just go on their website or call over there and you can get these marking beads. We want to do 3 on the outside and 3 on the inside. If it's tough on the lower, if it's small, you can do 3 on the outside, 2 on the inside, but try to get 5 and stagger them, okay? All right, so let's design the surgery, okay? So we've talked about, hey, Tim, great news, right? We've talked about a DICOM file. The DICOM file in itself, you can place an implant in the perfect position. Is it right prosthetically? Who knows? But the DICOM file will tell you it's really good. What about the STL file? The STL file is made to fabricate a guide with teeth, without teeth, what have you. And it lines up the future prosthesis. So now you can take the DICOM file, safely place an implant, and make sure that it's penetrating or coming out of where you want the future prosthetics to be. Win, win, win. All right. So now that we've done that, let's talk about designing the surgery. Okay. Well, we've got these 2 files. So if you have an iOS file, one file, your STL file is saved in there. If you have a CBCT, one file is saved in there. You can save it to your desktop. You can compress it, whatever you need to do. Bottom line is, just like you're sending an email with an attachment, you're going to do the same thing here. So we're going to go to the 3DDX website. I would try to go on. I think it's a hyperlink, but I think it's best that I not do that so I don't mess up the connection and all you kind folks waiting for me. So we'll do it in a different way. But nevertheless, when you open up the 3D Diagnostics website, 3ddx.com, you're going to see that they offer a plethora of services, and boy, are they good. They just really are. And as you can see at the bottom, full mouth reconstruction, single implants, multiple implants. They're doing, clear smile corrections. They're doing provisionals. It's a whole host of things. But anyway, nevertheless, we go to the website. What we're going to do right here is we're going to click on order services. Okay. And this is your own personal kind of like envelope, if you will, or folder, as you'll see in a minute. It's got all your previous history. It's got what's going on now, what's about to come up, etc. And it's really cool. It's iOS friendly. It's, iPad friendly. You could be in the middle of the Caribbean on a boat and you can do this. Okay, so as you see here, there's a few colors. So let's look at them. This is green. Green means I'm good, they're good, it's on its way. That part of the design is good, nothing for me to worry about, okay? So just like you check your credit card or you check your banking accounts, whatever, if you go on this every day or so, this kind of tells you where you are at, right? So here it says, oh, we've already received your intraoral scan. You're good there. If something is yellow saying, hey, don't worry about it. That's on us. Right now, we're reviewing the order. And when we have the order reviewed and we get a general setup of your surgery, how we know you like it, your default settings are saved, then we'll let you know by email or a phone call or whatever it may be. However, if you see something that's red says, hey guys, we're waiting on you. So they're not anymore, but as you can see here, it says, hey, we're waiting on your intraoral scan. Hey team, where's the intraoral scan? We can't finish unless we have the intraoral scan. And so you can see next to it, we downloaded it and off we go. So that is kind of like the bookkeeping of it, right? Well, okay, great. So let's order something new. Let's design this thing. So I'm going to hit fully guided design. And what's going to happen is we're going to scroll through a couple windows. And it's just basic windows. I don't need to go through them with you. I'll go through them. but I'll go through them quickly because it's pretty self-explanatory. Patient's name, what teeth are coming out, what implants are you planning to place, right? At the top, what's your implant of choice? Mine is Straumann. What are you going to be doing here? Hybrid. Are there other things that you're going to be doing that we should know about? And I put, yeah, sinus lift in number 3. And the reason I did that is because I say, if I put an implant number 3 and they look at number 3 and there's 6 millimeters of bone, they might be thinking, well, how's he going to do this, right? So I let them know, yes, I'm doing that. And I just walk through. It says, can you specify a time for a tuning session? And basically what that means is you'll typically have the same designer all the time that'll work with you. And I've been working with Dr. Epps now for about 5 years, and he and I can do a full mouth design in under 15 minutes because not only is he very knowledgeable and gifted at this, but he knows my likings, right? He knows how many implants I like, where I typically like to place them. So it's really, really quick. So it says, can you specify a time for a tuning session? And I'll show you what that looks like. And then ultimately, after everything's filled out, you agree, you are the doctor. They ask you when the surgery is. And yes, let's get started, okay? The next thing is they have other services, etc. But what you're gonna see right here is choose your file. And that's where you're gonna go and you're gonna minimize this window. You're gonna go grab your DICOM file and you're gonna attach it here. And so you see here, I go to .dcm for Lisa and I click it, you can see there, and then I'll submit it. And off it goes, right? So either you can do 2 scans from here, which one would be the patient wearing the denture with the beads, and the other would be the beads on this, and you can send them both through this channel. Or if you are doing an iOS, you would send one directly from the iOS, and you would send your DICOM file from your CDCT. Okay, and again, they're gonna get it, and they're gonna do this merge. So I'll do this again. A merge for the edentulous patient, watch the center cross sections, and they're gonna line up those beads. And now we know exactly, again, where the bone is based on where the canine is, and there's no drama, there's no mistake, etc. The next thing that's gonna happen is it's gonna say, hey doc, guess what? You got mail. Or they might call you or whatever the arrangement is, and they're gonna say, okay, it's time. And it's time for our fine-tune session. And so what you're gonna do is you're gonna go right here, you're gonna click on fine-tune. As soon as you do that, the next window is gonna open. You're gonna click right here. It's gonna say join now. Now they're gonna provide you with a go-to-meeting number, okay? So right there, you're gonna type in your go-to-meeting number, and there's my arbitrary number, boom, okay? And then you're gonna get someone that looks like Dr. Epps. That's Dr. Epps. Not really, but kind of. And Dr. Epps and I are going to have a go-to-meeting. And we're going to sit there and we're going to go through all of these cross-sections. The average time for full mouth, if you're getting started, I'd probably account for about 30 minutes. If you want to do it over the lunch hour, that's great. Grab a sandwich, grab a soda, and just sit down and do it. The other thing I love about working with 3D diagnostics, and it's a one-off, meaning it's not being done anywhere else, is that all the designers are actually doctors. And it's just really incredible working with people who understand that anatomy, understand some of the anomalies about anatomy that you might not even know, that they might point out, like a vessel underneath the canine that's traveling all the way across the arch that might be very bloody if you drill into it, right? So again, these are very, very smart, bona fide doctors who are dentists themselves and do combination practice and design. Okay, so let's continue. If you're really bored and you want to read an article, I typically do 1 or 2 a year. I've got a couple of coming up, but this is one from last year in March that I did, and I'm going to share this with you. Okay, patient comes in. I inherited this patient, and basically, this is what she has, essentially. She has a poor upper hybrid that was done very recently. And I'm going to talk about why it was poor. And this is a very, very, very tough scenario. Saving relationships, saving money, saving lawsuits, saving all of that, put me in a very compromising position. But the good thing for the other doctor is that I'm a pretty nice guy and I'll defend a doctor to the end. But it was tough. Okay, moral of the story is patient presents, and I'll just tell you now, the top was very thin, far too thin, far too thin, and I'll show you in a minute. So this left a problem for me because if I put her into occlusion with anything like zirconia, and I built her up correctly on the bottom to occlude with the top, I was going to destroy the top even more. So we had this conversation. I called the doctor. We worked through it. I accounted for some extra space in my design, and I gave him that space and told him to redo the prosthetic to save everybody's life, and he did. Anyway, so what you're looking at on the left is what? Right, it's the DICOM file. And what's on the right? Right, it's the STL file. So if I was just doing number 30, the STL file would be taken and that guide would be made to fit right over those teeth. But that's not what we're doing here. So here's an occlusal view and a facial view. Okay, so this is what I'm kind of dealing with. And yes, she's a grinder, and yes, she has parafunctional habits. And is this right for zirconia? And is this right for plastic or acrylic? And should we put her in orthotics? All this stuff. Guess what? This is a discussion in my classes amongst everything else, smile lines and transition lines. But in an hour and 15 minutes, it's very tough to accomplish. And we are at 1 hour and 15 minutes. Okay, so here's the subject, and this is where the occlusal table is. Okay, great. So this is where the occlusal table is. Now, why am I showing you this? Well, for the methodology of the design. So in a minute, I'm going to show you how we do wax ups based on the information that you've sent. Nevertheless, I sent this information, and one of the CAD designers, Jimmy, is responsible for overseeing a lot of these designs virtually. So Jimmy and I designed these teeth together. He actually executed the design. You need to give him credit. And so we were going from green to yellow. Does this make sense? And the reason that this is important is because this is the new incisal edge, all right? And the reason that that's important is because one of the most important things that we need to remember, separate of smile line and transition line, is what material are we using and how much space do we need? Because from the incisal edge of where the teeth should be down, I can't interrupt that space. If I do, I'm gonna have a cracked prosthesis. So if you look here, this is a general rule of thumb for space. It's a little bit aggressive, but if you look here, from the top pink line to the bottom pink line, that is about 14 millimeters in my world. So let's look at this. I take the new designed incisal edges of the teeth. I account for 14 millimeters of space to use zirconia in my average case. So my implant platforms cannot be above that space. You understand? So that green square rectangle that you see, that is going to be all bone removal. Bone removal is not arbitrary. So if you're new and wondering, how do you remove bone? It is not arbitrary. It can be if you do it freehand, and it might work out well. You might be too short. But ultimately, if it's a math game, what we're doing is designing the teeth, getting the incisal edges in the exact position that we need, and working 14 millimeters down. And that space cannot be interfered with. Then that's where the platforms of the implants go. Now, how far down can you go from that? Just depends on how much bone you have. Do you have to go to an 8 or a 10 or a 12 or a 15 millimeter implant? Do you have to angle the implants? You just can't exceed that bottom purple line in terms of the platform height. Otherwise, you're going to make your prosthesis too thin, you're going to break it, and there's no solution to that typically. Okay, so moving right along, something like this, 14 millimeters is something that you need. If you go to Tybar or any of these things, talk to your lab. They're all space specific as to what they like. You need space, otherwise your implants are going to integrate. You won't be able to give the person the prosthesis that they paid and hoped for. Okay, so this was the top prosthesis. 10 months old, she paid $23,500 for it, told it was porcelain, and this person has stuff cracking off. And if you look at this thing isn't even 10 millimeters thick. Number one, it's not thick enough for zirconia, let alone acrylic, okay? 10 months, look at the wear on the back of those anterior teeth. This is a very difficult proposition. So guys, it might not seem like a big deal, but thickness is huge, and this all is in the design. Okay, so let's talk about stackable surgery, okay? Now, we've taken all of our files, we have an idea of where our teeth should be, and we work down. Again, I know this is very abbreviated the way I'm presenting this to you, but again, we only have so much time. We're going to start with something called a pin positioning guide. The pin positioning guide basically is a guide, not basically it is. It's a guide that is made and fabricated to sit on the top of the new virtual wax up. Okay, excuse me, I apologize. It's designed to sit on the patient's teeth, but accommodates every other guide after this to accommodate for the virtual wax up. So what you're looking at again, for clarity, is this is her natural dentition, and you have a pin positioning guide on. Now those 4 pins that you see, that is the stage for the entire surgery, all the way up to the final delivery of the teeth. That shall not rock. If that rocks, we have big problems, especially if you proceed. So what we talk about is the windows that you see open to see clarity with the cusps. How many windows? Where are they positioned? Where are the pins positioned? How deep do they go? This is all in our class, and we'll talk about that at the end. Now, atraumatic extractions, okay? And what you can see here, atraumatic extractions, they're done a couple different ways. I now actually flap the tissue before I remove the teeth. And the reason for that is it elongates the vestibule so we can get the guide pins down and they're easier. But nevertheless, what you see here is a very clean reflection. Why is it clean? Because I understand anatomy. I know where I'm at and I know what's going to help me in surgery. If the patient's numb and the patient's leaning back and the patient's comfortable, they could be bleeding all over the place, saliva all over the place. It's not going to affect them. It affects me, right? As a surgeon. Look at this working field. It's so clean and clear. So what I'm pointing out here on the lower right is you can see the PPG holes. Everything now will go into those holes and it will develop the height and all of the math off of the wax up that we did, okay? All right, so the next guide that's gonna go on after the teeth come out are going to be the bone reduction guide. Passive fit, but stable. Now you're gonna see a couple guides. Some we're going now to magnetic guides, which I love, and they do a great job at it. But anyway, we want this thing to fit passively. You wanna make sure all the tissue is out of the way. Are you comfortable with the mental framing? Happy to help you. If you don't know how to dissect around it, you need to learn, okay? Then what we're gonna do is we're gonna flatten the ridge like you see here, all right? So we are fulcruming, we have two hands on the handpiece. This is a bone reduction surgical bore at 1:1. And ultimately, we're gonna flatten everything out nice and smooth, a lot of water, keeping the temperature down so we don't have problems with bone death, okay? And ultimately, we want something that looks like this. Think about it in your prosthetic days, if you did prosthetics, as a reduction coping from the lab, okay? You want to be equal on the horizontal and the vertical. So the next thing that's going to go in is the implant guide. We want to make sure that that fits nice and intimate. This is an older version of a guide. The new ones that we're doing now are magnets. All the implants go in. Now what you see here is abutments are in place, and it's exactly designed to the plan that I made. You can even see on the lower left, you can see how that one implant needed to be tipped lingual. Well, look at it on the lower right. It's exactly in the same spot, 1/25,000th of a millimeter off of the original scan. That's really amazing. That's clean, that's quick, and it's just exciting to me that I can have this kind of control and cleanliness. Ultimately, comfort caps go on, we suture, we trim tissue, and we fabricate PMMA, and she's out. Okay, I'm almost through here. I want to show you two more cases, and I love this one. I love all of them, but I love this one. Meet Shara. Shara is her name, and I asked Shara when she came into me, don't look at the right away, look at the left. That's her face, obviously. And I said, Shara, smile. That's her smile. She smiled like that. Now, I want you to know when a patient smiles like that, that is almost a surgical nightmare, to be honest with you. Because as soon as you make that person happy, that person will never smile like that again. And now, where is the transition line? Where's the top of the zirconia bridge or the top of the hybrid, right? So I asked her to smile, and what she did was she lifted her eyebrows and lifted her cheekbones. So the only way I could actually see her teeth was retracting her lips back. Well, you could see why. Look at her lower right. It doesn't matter why she's this way. If you get in the habit of, asking all these questions about, how long did you do this and why did you do this and what happened here and what drove, the bottom line is that's what she presents with. And our job as oral clinicians is to support her and take it today and make her better. Okay, this is cool. I worked over this over the last couple of days because it's hot off the press. The material as I did the case about 3 years ago. But anyway, here's how she presents. So the top, again, scalp view, and you see the panel view. On the lower are the cross sections, and it might be a little dim to see, but what you can see there, if you look closely, is implants in there. You can see the emergence profile of the cingulum coming out of the cingulum. You can see where the guide is. You can see where the sleeve is. Everything's in each position. So prosthetically, I know I'm correct. Okay, let's move on. So here's the STL file. You've all done iOS scans before. So we're going to go inside Shara's mouth, no matter how bad it is, because they're affixed to her head. And we are going to do an STL file, and we're going to get file scan number 1. We have the CBCT, so that's our DICOM. I just showed you that. And here's our second file, okay? Now, we send this over. The gray on the right is the DICOM file. The orange and the green represent the STL file. And so she's mounted virtually, okay? Is the video correct? Hers was within a millimeter or so. Really quick, off the beaten path here. If a person looks like this and you have no occlusion, what you can do is you can stabilize it with either just a wax rim and or a temporary prosthetic like a denture or a partial or whatever. You're going to take scan 1 and 2 intraorally with those things in, okay? You're going to take the culprit arch, which is in this case the lower arch. You're going to take a scan of the lower width, and you're going to take a scan of the lower width out the partial denture, and you're going to take a bite, okay? All right. And you can also send in impressions again. So here we have her. She was at 68 millimeters of VDO. We opened her up to 70 because I wanted to give her some incisal edge back. Now what we do, now because we have her virtually articulated, now I say we, I'm not doing this. I don't have the intellect to do this. Jimmy from 3D Diagnostics is doing this. He says, okay, Doc, well, I got your VDO, I got your midline, I got everything right. Now, why don't we give her some nice teeth on the bottom? Okay, go for it. Now, guys, here's something that I told Jimmy and I want to tell you. If a patient is doing both arches, whether it's a year or 6 months or 4 months, you have to have the discussion about designing together. Because if they're not as bad off as Shara is here on the top and they're okay, they have a reverse curve, they have some things going on, and you make a lower to fit that, well, now you're kind of blocked out backwards later. So you want to make sure you have that discussion. And she said there's a really good chance that she's going to do her lower arch. She just wanted to get through the first surgery. I said, great. Hey, Jimmy, why don't we do this? Why don't we design something ideal on the bottom, which you see in blue? And why don't we design something on the top that meets that ideal? But at the same time, the blue on the left will work pinpoint contacts with her maxillary occlusion as is. And that's exactly what we did. So we articulated her virtually with the STL file, okay, and with a DICOM file. And we sent this in. So you saw her, what she was. Then we opened her up virtually. Jimmy did, I didn't. The reason I keep saying I didn't is because I want you all to think that you don't have to have that knowledge to be able to do that. So then we designed a lower to go with our existing upper, and we also designed an upper to go with the new lower. Okay, let's look at the case. So here's the case. So as you can see, working down, we gave 14 millimeters to accommodate for the thickness of the material. You can see the teeth are slightly facial to where the bone is and where the positioning is, and we did that on purpose. When you look at a 3D rendering like this, it's not always correct when you're looking top down. If you turn it to the side, it looks a little different. But when you look at the cross sections at the bottom, we're right over teeth. We've extended beyond the apical socket. Everything is emerging through the cingulum, and everything looks great. Okay, great. Here we go. Now, what's really interesting here is here's the implant. That yellow pole going up is the emergence profile of the implant. Perfect, right through the cingulum. Fantastic, right? This is 14 millimeters of thickness. That is why the implant platform is planned there. So I've accommodated perfect screw access hole, okay, based on a DICOM file, based on the STL file. I've accommodated the thickness for the future material, which is 14 millimeters, and that's where I start to place my implant. Could I go deeper? Yes. Could I go shorter? Yes. I don't know what that is, probably a 12. Typically, my immediate load cases average 12 millimeter implants with Strongman. Okay, so we've got the design in, let's go, okay? So here's a pin positioning guide, moving right along. We reflect everything. The bone reduction guide goes in. Okay, now, one thing I want to mention to you here is, guys, if you're doing immediate cases, please be really, really cautious about the atraumatic extractions, because these diseased teeth, like you'll see in the lower center on the bottom, which was Cher's case, the bone just wants to come right out with it. Unfortunately for all of us, I was very lucky, which we could see on the CBCT, but it didn't break or distort past the reduction guide, because you will lose a lot of stability. Okay, here's the bone reduction guide. You see various version of that. Here is just a little video on reducing bone, which I've already showed you. So we're going to reduce nice and easy fulcrum and get it nice and even with the facial aspect. Okay, now we get it even, as you can see here, everything's nice and even. Now I do want to show you this. This is a spot where, again, the beginning to novice will get caught up, because the next thing that's going to go on here is your implant guide. And it won't go down if you don't pay special attention to where the vertical meets the horizontal, okay? Where the horizontal meets the vertical in the posterior part of the guide. So here's a cross section. That's a cross section of the vertical and horizontal. And if you have that lip of bone elevated above that layer, like you can see on the left, you will not get this guide down. You will not get the implant guide. It will have interference. This is what you want the posterior, horizontal, and vertical to look like. A perfect, nice, clean corner. Implants aren't even actually going back that far, so sometimes I even ditch those a little bit. Be mindful of, obviously, anatomy, okay? So implant guide goes on, no problem. So the sound's a little low on this video, but what I'm showing you is I'm using my instrument to show you how that margin is closed between the two guides. Totally nice and smooth. Everything's closed everywhere. We've gone away from these little latch type connections. We're now doing magnet. But if you look to the other side here, that is just sitting right in. So the implant guide has the female part. The bone reduction guide receives the male part and it slips right in there. And that's when you know everything's down. If it's lifted on one side, your implants will be off. Okay, so here I go with my drilling. I'm pumping in and out, adding a lot of irrigation. I'm doing one implant at a time. Then ultimately the implants are going to go in, and there's certain dictated depth to all of these implants. And we're driving this implant in based on time. I'm going to move away from that as well. Now, how do we do all that? Well, depending on what kit you're using, what implant you're using, the silhouette of what you're using, after you do the design with 3D Diagnostics, you're going to get a recipe that looks like this. And for Strawman, it tells me, here are the sizes, here are the depths, here are the handles I'm going to use, and we kind of fly through it. So all of this is based on the algorithms of the design, okay? So here we are. Wow, look at that. Look at that. I'm so pleased. I have 5 implants in exactly like the design, okay? Then the angulated abutments go in, upper left, upper right. I did a connective tissue graft. They were held down by the screw retained abutments. On the lower left, we use comfort caps, we suture. Then we take the pre-cut temporary cylinders, put them on, and we take the pre-cut rubber dam blockouts, and we take the PMMA that's provided in the stackable, which has legs to fit into the bone reduction guide. And then look at the pin, look at the positions of those implants. The implants have red caps in them, or the cylinders have red caps, so we don't get any acrylic down in there when we pick up the hybrid. But look at that accuracy. And we're talking about an hour and 15 minutes, okay? Now, here's the best part. We get her into occlusion. I apologize if the picture's a little blurry. It's taken from a little bit lower, but she's in occlusion. She's hitting in the posterior. She's slightly open in the anterior. We knew that was going to happen. And I said, so Shara, go home, think about it, and whenever you're ready, I'm ready. She called the office in 4 days. Now, just so you know, an average patient like this will have a pain tolerance, or not a tolerance, a pain scale between 0 to 2 for 2 or 3 days, not even. Sometimes they come in and say, honestly, doc, I feel like I'm fatter than I've ever been in my face, but I don't have any pain. This is the truth, all right? So here we are, we started with that, and we want to go there. Guess what? She calls back 2 weeks. She said, I'm ready. She came in 2 weeks later. This is where she started. This was after session 1. This was after session 2. Holy cow. These are her temporaries. And all of a sudden she figured out how to smile. She figured out how to open her lips. She opened her lips 14 millimeters. If I didn't account for that, you'd see the whole transition. So for me, the transition line's 2 millimeters beyond the lip line. We talk about that in all the classes, but there you go. There's a retracted view of what she was before, what she was after. This is 2 procedures live with her. Each procedure is under 4 hours, and she's a different human being, okay? And you can see it's exactly like the design. And if you're going, wow, that's nice, that's clean, that's so cool. I totally agree with you, 100%. It is cool, and it is clean, and it is life-changing, and I'm very proud to have done this for her, okay? So This is going to be one of the last slides, and I just want to, again, thank you. I know that we've gone over about 15 minutes. I hope you've enjoyed it. I've tried to condense as much as I could into this short amount of time, but I want to give you some things to take home to think about. I'm going to give you 10 things, okay? Get your cameras out or your phones out, or you could write them or none of it. Totally up to you. Okay, number one, where is video? Where will video be? Are you able to assess that? Okay. This is huge, guys, huge, okay? Because with video change comes angulation change. Do you understand the smile line? Do you understand something between a rest smile, a social smile, and an exaggerated smile? Watch someone hit the lotto. They will give you an exaggerated smile. Are you ready for that? Number three, transition line. Are you familiar with transition lines? I think those two things, number 2 and 3, kill the average surgery done by an individual who is unfamiliar with this. Those are massive because the implants are in and you can't change that. What are you using for prosthetic material and why? Okay. Do you know the space requirements? May sound easy. You might be like, I want to get my implants first. I want to make sure I don't hurt the person, suture them up. I'll figure the teeth out later. Not good. Not good at all. That could be a big problem, okay? Number 6, are you aware of the AP spread distribution, anterior to posterior implants? Are you aware of cantilevers off of an AP spread? Do you know what those demands are? How far back can I go? Can I go to the first molar if I only have implants to the canine? Maybe not. What if someone pays you $25,000 and you put straight implants in the lower, and the lab tells you that they can't go past the canine? Something to think about, right? Easy check to deposit, very hard one to write. Quantity, how many, and the position of the implants. Do you feel like you understand where that needs to be? Number 9, do you know what implant is best for the type of procedure you're doing? The silhouette. I love the BLX. It's an implant that really is optimal for immediate load, and I don't go away from that. We do about 1,000 of them a year, implants, and very rarely will you see anything in my hand other than a BLX for this stuff. Once everything integrates, then it doesn't much matter, right? But to get immediate load and stabilization, we need some mature implant silhouettes. And here's the best one of them all. Are you qualified and capable? You know, I talked about changing people's lives. And as I sit here and even say that to you, I take a gulp because I am so honored that I can. And I'm so honored to feel what I feel after the patient gets up and cries and hugs me, right? But I want you to know that for all of the ways that we can make their life incredible, we can also make it miserable if we do the wrong thing, or don't understand what we're supposed to do, or aren't capable, or don't have that uber mentality. So please, for me, for you, for our profession, keep growing, keep doing what you need to do and what you love to do, and that's awesome. But stay in your lane, okay? We do have mentoring classes. I'm known for the first guy in America to do private courses with live patients. We do a mentoring 1, 2, 3, and 4. What you just saw is taught in mentoring 4. We only take 12 doctors. And we do 4 courses a year, and they fill very, very quickly. Every doctor gets to do a complete full-on, all-on 4 case, or all-on case, I should say, all-on X case with our mentorship. And it's very small. We only take 12. We have 2 surgeries every day. All doctors participate in them. And we obviously elaborate much more than I have in this hour and 15 minutes. It is 1 day of lecture. I do a demo surgery live for you like you just saw. And for 3 straight days, we see 2 patients per day. And it's really just incredible. This is the last course that we did, doctors and mentors and staff. And this is me in my element. It's what I love to do. We record stuff and take pictures with stuff, with you and with doctors and all that stuff. That being said, that's me. I'm not a big social media, Instagram fiend, but I like putting cool stuff out there that I think can help you learn. And I'm known for doing what's called the learn at the end of my post, and it just points out something special within that post. So it's Todd Engel DDS on Instagram. And let me one more time say thank you to all of you for being up late at night and watching this kid who had a dream one day to do this. Khaled, thank you. Everybody, Greg, Dr. Epps, Omar, Jimmy. If I've left anyone out, I apologize. You know, I love you all. Everybody over at 3D Diagnostics, you're great people, but a great company as well. And again, thank you guys for tuning in. It was really awesome, and I love doing this. Hope it showed. Cheers. Be safe.
Absolutely. Thank you so much, Dr. Engel, for a very informative and engaging presentation tonight. I know I learned a lot. I always do whenever I hear you speak, and it's been more than a few years that we've known each other. So I hope our participants learned as well tonight. There weren't any outstanding questions. I've been fielding them, and the panelists have been fielding those as well as we've gone along. There's been a number of really great ones. The comments are coming in, you know, with kudos to you, including a couple of individuals who will see you at M1 next week. So that was exciting to see as well. So you have a couple of individuals who wanted a preview for the full arch before they get to M1 in the whole continuum series over at the Engel Institute. For those of you who are interested in more information, you can go to www.3ddx.com. And just so you know, it has been recorded and it will be housed on our YouTube channel as well. All of our previous webinars are located there. Dr. Engel has done previous webinars for us as well. So you can go there and find this and watch this webinar or previous ones done by him or others. And please be on the lookout. Here's a little teaser for you. Dr. Engel will be doing a future live surgery webinar featuring Dr. Todd Engel, where he'll be performing.
Featuring Dr. Engel. That's awesome, Greg. I love it. Hey, Allison, I love you.
Some of what he's presented here tonight, he'll be doing live in front of a viewing audience. So we're really excited to be able to share that here in the next couple of months. So be on the lookout for that as well. And thank you so much, everyone, for attending. And I hope you have a great night. Thank you very much. Have a great night.
Bye, guys. Thank you all. Have a good night.